Button.
Hey, and welcome everyone to the post-summer 21 Calgary's own primary care webcast. Rick Ward back with you, helping to host tonight's session with my friend and colleague Christine Lalo. Really good to be back. Sort of wish we weren't talking about COVID, for the love of goodness, but those are the days that we're in. We'll start off maybe with just land acknowledgement, just reflecting the location and the respect for the First Nations. Um,
Those of us that are continuing our oral history are blessed. What we shared, that was told from way back.
We were part of the ecosystem. We were not masters of it.
After we grow up from our biological mothers, the earth becomes our caregiver. Everything that we need is there.
We were raised to believe that everything has a spirit, and that everything around us is alive and has a purpose.
The spirit of the land and our spirit. You can't separate land and people.
In Treaty 7 territory, I'm accepted, I'm something, and I'm with my people.
We honor our ancestors by acknowledging Treaty 7 territory. We acknowledge the Treaty 7 nations, the Piikani First Nation, the Siksika First Nation, the Kainai First Nation, the Stoney Nakoda First Nations, and the Tsuut'ina First Nation. We acknowledge the ancestral territory of the Siksikaitsitapi, the Blackfoot Confederacy, and the home of Métis Region number 3.
And thanks. And we'll just start off then with, I believe, my disclosure slides. For those of you who have been keeping track of my disclosures, they have not changed appreciably over the summer, so I will not go over them. I wonder if you could share the agenda for tonight, Trevor. And as you can see, we have an eclectic evening presentations. We're starting with fecal transplants and moving along to talk about public health perspectives in the fourth wave. So there is a theme of things being crappy tonight. And I've been told I'm only allowed one-liner tonight. So that is it. And without further ado, let's get to that first topic. Val Taylor. Val is the head of the Division of Psychiatry for the Calgary Zone. I won't say newly minted because it's been a couple of years, I think, Val. And she brings a very unique topic tonight. So, Val, welcome. And I think that the question on most of our minds are, okay, we've heard about this fecal transplant for Clostridium difficile, but depression, really? Tell us more.
Yes, it may not necessarily be intuitive, but you know what? It's actually intuitive for a lot of patients. And so for us, this is actually the second of 4 studies that we have looking at fecal transplant. The first of which is a study for bipolar depression, which was started in Toronto and is closing now. We've finished recruitment. And the preliminary results are extraordinarily positive, so much so that we were able to get other funding to look at this for other indications and the other mental health indications. And of course, depression is where we moved to next. And I think that may not be intuitive, but there's actually a number of links between your GI system and your brain. We know that individuals who have GI illnesses like Crohn's and colitis, much more likely to have mental health problems, even if you compare it to other physical health problems that don't impact the GI system. So it's about the GI connection and not the fact that people are physically unwell. There's a very small but extraordinarily positive fecal transplant study done in the US for autism. So, they've actually moved that to a much larger study, again, because the results were very positive. And I have to tell you that it might feel strange to us, but when you actually ask patients about it, they are all in, because many of them actually feel like there is a connection between their GI symptoms and their mood symptoms. And they will often tell you that the two things are related. And so for them, this actually makes a lot of sense.
Yeah, interesting. I mean, the talk about the gut biome and many diseases is really becoming more and more prevalent. I know that there's some interesting data in the hypertension world about hypertension being treated by modifying the gut biome. So I know if Christian Turbide was online, one of our local gastroenterologists who's quite interested in this, he'd be jumping up and down. So this could be the cutting edge, maybe of the direction that we're going. So Val, when we think about treating patients with depression with fecal transplant, I mean, what does that patient look like? What's the profile that you're studying, and where do you think we're going with this from a therapeutic standpoint?
Absolutely. So as I said, we did bipolar depression in when I was at U of T, and of course that's a really challenging illness to treat. We've since moved into depression because this, and of course everything is approved by Ethics and Health Canada, and it's extraordinarily safe. What we're looking for our studies, which are, it's a lot of the patients that are seen in primary care, are individuals with depression whom have failed to respond to current treatment. So current antidepressants don't work. And so we're looking for people who have failed at least one previous treatment and are now on their second and aren't responding appropriately. But we're not looking at treatment-resistant depression. So no more than 4 different treatments. So if they've failed 4 treatments, often the prevailing theory is that perhaps there's something else going on, and it's PTSD and depression, or it's other entities that require further evaluation, and that's not what the study is looking at. And so it's individuals with depression haven't responded to treatment, to at least 2 antidepressant trials, but not more than 4. And after that, we're pretty open. So anybody over the age of 18 whom has a predominant diagnosis of depression, they can have anxiety, they can have PTSD comorbid with it, as long as the PTSD is not first. They can have borderline traits, as long as the borderline is not the prevailing diagnosis. And so we're they can smoke marijuana, they can drink alcohol. We're pretty open. And what we will do then is we'll follow them in our research program to provide them with psychiatric care as well. And they'll be randomized to either fecal transplant pills. And so that's the other good thing in Toronto. When we were recruiting, we were actually recruiting individuals with bipolar depression to get fecal transplant via colonoscopy. As you can imagine now, individuals who were depressed and didn't need colonoscopy signing up. And again, we had a lot of people volunteer for that study because it made sense to them. We've been able to move forward and remove the colonoscopy aspect from it. And so it is oral pills. So just like they take their antidepressants, they'll take these other medications as well. And hopefully we're going to be able to, 2 things: figure out what's going on with the gut microbiome in individuals with depression, which can hopefully inform further treatments, and see if this actually is as successful in unipolar depression as it appears to be in bipolar depression. And I'm hoping, if nothing else, it's actually going to be more successful.
Yeah. So, Val, and maybe I missed the nuance, but so what's a course of treatment then, according to your protocol? How many days are they on therapy, and is there a maintenance protocol?
Yeah, so right now it's a 12-week trial, which is actually longer than most antidepressant treatment trials. And they get dosed at every time point. So kind of first a week or so, then no treatment for a few weeks, then kind of at the midpoint, and again at the end. And we will follow them after the 12 weeks as well, because we want to see how long this is maintained. In our bipolar trial, again, with bipolar depression being more complicated to manage sometimes than unipolar depression, 6 months out, people were still remitted in terms of depression symptoms. And so, we're very invested in kind of following individuals long term to see what's going on here as well. And we've had Facebook ads and posted for a little while, and we've had over 500 people respond to the Facebook ads. I've actually not seen anything like it. This makes sense to patients, and we have preliminary data to show that it actually works in mental illness. And so we're hoping that we can connect with other clients who might benefit as well.
So, any theories in terms of the pathophysiology? Why the heck does this work?
We have, again, might not seem intuitive, but this, and it might sound a bit science fiction-y, but this is actually not new. In the 1800s, this was actually how people treated mental illness. There was a lot of work in this space, and people actually, the affluent individuals of the day who were experiencing kind of what they would call burnout, or at the time melancholia, would go to these spas or sanatoriums where they would basically, they called it a detox actually, and what they would do is they would eat a very bland diet. And the thought was that by changing up the diet that people ate, you changed the toxins that were produced in the colon. And they called this the auto intoxication theory of depression. This was how many people who were experiencing stress, which probably would map onto what we're calling depression, were treated. But of course, as sometimes is want to happen in this space and with mental health or mental illness treatments, people started to take things too far. So first, we didn't have the science back then that we had now, in order to understand exactly what was happening that was making people feel better when they changed their gut microbiome via diet. And they started to move into what they called psychosurgery. So basically, they figured that by changing the gut microbiome, you improved brain illnesses. And so would take it a step further, and they started doing surgeries where you remove parts of the colon in order to treat illnesses like schizophrenia. So as one can well imagine, surgeries in the 1800s on schizophrenics who did not want to have surgery didn't go so well. And there were a number of deaths. And then at the same time, the whole monoamine theory of depression sort of came into the forefront, and we started to have the discovery of the first actual psychiatric medications with chlorpromazine, and people starting to kind of think about neurotransmitters and that kind of thing as perhaps being the next big wave. And so people moved away from the gut microbiome, and now we started to come full circle in that we have the technology to actually look at what's going on in the gut microbiome. We have probably, unfortunately, there have been no new drug discoveries that really impact the neurotransmitter system in mental illness for depression. Probably in a good 20 years, really. There's a lot of Me Too compounds, but nothing new. We know that probably 50% of patients don't respond to current treatments, or don't respond very well, or have significant side effects. Obesity being a big one, cardiovascular disease, diabetes. And so we need to do something different. And there's more and more evidence that this might be the next big thing. There's a number of connections. We know that neurotransmitters are produced by gut bacteria. So they're actually involved in neurotransmitter production and metabolism. So serotonin, dopamine, all of those things. We know that cortisol production via the HPA axis actually impacts gut permeability. And so the so-called leaky gut type of presentation, of course, what that does is trigger inflammation. And so when people are stressed, bugs in their gut get out that shouldn't. It causes inflammation. We know inflammation is linked to the etiology of mental illness that causes, a inflammatory reaction that actually we see the same sort of thing happening in many of our antidepressants designed to treat this inflammation. So it's that sort of link. We also have this really interesting connection via the vagus nerve, which is a direct connection between your brain and your GI system. And people started to understand the role of that a little bit in terms of mental illness when they did vagotomies to treat peptic ulcers. So by cutting the vagus nerve, it would treat or impact acid production in the stomach and help treat peptic ulcer disease. But it also, by cutting that connection, there was a increased incidence of neuropsychiatric disorders suddenly developing in people who had never had psych illnesses before. So severing that gut-brain connection predisposed people to start experiencing psychiatric symptoms. But I think the most fascinating stuff is some of the animal research, which we're now trying to translate with these human fecal transplant studies. And people have been able to show that if you take stool from humans who have different mental illnesses, so stool from people with anxiety, depression, even autism, and transplant it into germ-free mice models, the mice start to develop these types of behaviors. If you take stool from someone who's depressed and you put it in these germ-free mice, the mice start exhibiting what we call depressive-like behaviors. If you take it from an autistic individual and put it in these mice, mice start showing alterations in social interactions. And so, for me, this is kind of wild on a couple levels, because it also shows that mental illness is communicable. Like, you can catch it by this stool transfer. And so how does that, if you can catch the illness, hopefully you can treat the illness by taking individuals who have these illnesses and hopefully changing up their gut microbiome with something that's extraordinarily healthy, to see if we can essentially reset the gut microbiome. And so I think that, that's just some of the research that has led us to kind of get involved in what seems like a bit of an unusual area of research, but one that we actually think is going to really be the next forefront, perhaps, of drugs designed to treat mental illness. And there's a different way of conceptualizing it.
Wow. Another good argument, if you're not depressed, to wash your hands really carefully after using the washroom. You don't want to catch depression, not to mention COVID and all those other things.
Exactly.
Val, I think of depression and mood disorders as being pretty heterogeneous. Is there any sense that certain kinds of depression, like an anxious depression or a retarded depression, any characteristics that are more associated with gut biome and maybe more responsive to fecal transplant?
So that's actually a great question, Rick. And so we kind of have two things that we're doing right now. One of which is fecal transplant, and part of that is going to be looking at, are there any types of presentations that respond? And the other is really in keeping with the University of Calgary's focus on precision medicine, that we have a very large biobank that we've started, and we're collecting stool samples on a myriad of different individuals whom have anxious depression, psychotic depression, atypical depression. It's part of what's always struck me as being a bit unusual, and really a lot of the patients too is, if you have OCD or panic attacks, or you have depression and you sleep too much, or you have depression and you don't sleep enough, we give the same pill to them. And there's so many different presentations, and this may be why we have so many people who don't respond. We're not specific enough in our treatments. And so we're really working to try to figure out if there actually is a microbiome signature that may be associated with these different illnesses, and that there's a, from a bacterial perspective, they all look a little bit different. And so, we have the two pieces of research happening right now. So we have the fecal transplant study, and if people are interested, the website to refer patients is FMT, so fecal microbiome transplant, so FMT MDD study at UCalgary. But of course, if you can't remember that, you can just email me. Most people can find my email somehow, and I will absolutely provide you with any information. And then the biobank is called Orbit. And so it's just orbit at ucalgary.ca. And we're really interested, especially in people who are perhaps outliers. And so if you have someone in your program who is new to you and they have depression, they haven't taken medication, you're going to start them on a medication for the first time, give us a call. The other good thing is that most of this stuff can actually be done remotely. For the fecal transplant study, there has to be 3 visits into the university, not into the hospitals, to pick up the fecal transplant capsules. But otherwise, most of the visits are done remotely, and we get stool samples, which people can pick up the kits when they come get their pills and send the stool samples back via courier, so they don't have to come into the hospital at all. With the biobank, we can mail them the collection kits, and they can send them back via courier, so they don't have to come in at all. And so, it's people who are going to start an antidepressant, so we get samples before they start the antidepressant, and then at various times over the course of their treatment. If you have people who are extraordinarily treatment resistant, nothing seems to work. We're really interested in looking at their microbiome, which again, it's not hard to get. It's not like even as difficult as giving a blood test. It's something we all do pretty regularly anyway. And so the patients also get paid for it. So, hey, it's going to happen. So, and then of course, people who respond in really peculiar ways. So people who lose weight or don't put on weight when they take medications that we know cause most people to gain weight, like olanzapine or Remeron or mirtazapine, high dose quetiapine. People who kind of take stimulants and fall asleep, people who take sedating medications and are wide awake, anyone who the outliers. And so we're interested in both, kind of getting data from massive people who have true atypical depression, true anxious depression, true psychotic depression, to really see if that's a numbers game. The more people we get, the better we're going to be able to refine our treatments. And so it's both of those things that we're interested in, so that we can actually make fecal transplant a little more specific. And so right now it's sort of it's fecal transplant taken from extraordinarily healthy individuals that is then kind of processed and refined down. But maybe we supercharge the fecal transplant by adding in certain bacteria that we know are deficient in different types of depression presentations. And so that we can have a more precision medicine focused approach. There's machine learning in interpreting the microbiome data to see if the computer can actually pick out patterns that we're not sophisticated enough to see with our own meager little brains, because there's trillions of bacteria and there's a myriad of different ways to diagnose depression. And so it's figuring out, are there particular patterns that seem to be linked to particular illness states? And so we're pretty excited about taking both areas forward. And we're really hoping that we're going to be able to create some made in Calgary unique treatments and offer treatments to people here in Calgary and patients here at Calgary. It gets really hard for me when we, at least once a week, I get an email from somebody who is outside the province or outside the country asking to participate in these studies. And of course, because they're Health Canada regulated, we can't ship product elsewhere, and we can't, even without COVID, we can't tell people to come hunker down in Alberta for 12 weeks and be part of a research trial. That's just not how research happens, but of course in COVID times it becomes extraordinarily more complicated, and so we don't want anybody ever doing that. So we at least can hopefully make it available to people here in Calgary and surrounding areas.
That's great. So Valerie, we've only got 2 or 3 minutes left, and I've mentioned in the chat box that I think with Keith's help, we'll do a one-pager maybe that we can follow up with all our family physicians about sort of the different patient profiles that you're looking for, and also the best way to connect those patients with you in your office. And I think that handles the questions and comments by Muriel and Lisa and Cassandra as well. Heather asks a good question about where do you get this good poop from? Where on earth who are the donors for the good stuff?
You know what? That's actually a great question. It's one of those weird studies where sort of that intervention and the control groups are harder to find than the participants. These are, if you think about the kind of the things that you need to do to donate blood, so it's that safety protocol with about 20 extra pages of regulatory stuff, and being BMI between kind of 20 and 25, no history of mental illness either in the individuals or in any first degree relatives, no chronic illnesses, no travel, which at least is easier these days, to foreign countries, no antibiotic use in the last 5 years. It's I'm somebody who has no allergies, no chronic illnesses. I take no medications. I've not used antibiotics probably since I've been a teenager, and I am not healthy enough to be a donor in my study for about 5 different reasons. Now, these are very healthy individuals. And so if you also happen to be somebody that you think might qualify as a donor, please don't hesitate to reach out. You may have super poo that we can take advantage of. We're always on the lookout. And again, you're going to do it anyway, might as well get paid for it.
No shot. I mean, and I can tell you, I've excluded myself already. I will not be giving you my poop. Nobody would want that stuff. Val, thanks so much. I think I had to throw in a couple of other one-liners, so I apologize. No more. Really cool. Thank you for spending the time with us tonight. And for colleagues, we will get a one-pager that sort of puts this together so that you can connect your patients with the study. Cutting edge stuff, and we'll have you back next year and maybe hear about the results. This sounds like a real paradigm changer.
That would be awesome.
Really good. Thanks, Val, and we'll let you sneak off to your next.
And I'm sorry, I would have loved to stayed on actually. This is fabulous, but I'm double booked, so you take care.
Right on. Thanks. Christine, holy smokes. Are we going to start throwing out our SSRI samples and putting prescribing poop to everybody? It's a bit of a game changer if the research shows that this is an effective treatment. Wild.
Yeah, I think about how different my day in the office today would have been if this was already mainstream. And it's an interesting segue into some of our later topics where we're talking about wastewater monitoring for COVID as well. So I think what we all know to be true is that our time on the throne is something that's going to happen every day, as Val already said, and maybe is more important than we ever thought before. So.
Well, hey, speaking of sort of what's been happening and the lay of the land, it's been a few months since we've had the chance to sort of dialogue and chat with colleagues. Where are things at in your office with your patient panel, with your colleagues? How are people riding the fourth wave?
Yeah, it's funny that sometimes, in the office, it's almost like you can forget what's going on with the pandemic, because people are still making babies and people are still coming in for their rashes. And, there's a strange normalcy in some ways to our day-to-day work and family practice. and at the same time, that constant reminder of the mask on your face. And I still try to every day celebrate some of the things that have happened positively as a result of these last 19 months. I would count these webinars as one of those positive things. I think it's brought us together here in the Calgary zone as a family practice community in a way that maybe we haven't had before, which is kind of cool.
Yeah, I know that in our office, I think we're all feeling a little bit fatigued by COVID. How many patients in a day do you hear say, "I am so over this COVID stuff"? But we're also seeing our patient volumes go up, patient calls and demands going up significantly, like about 30% increase in phone calls over a similar period pre-COVID. Is that what you're saying in your office as well?
Yeah, it's, I think there's one part, probably some mental health burnout for not just ourselves, but our frontline staff. And, how efficient are we with the work that we do, given that we're all burnt out? One part, that mental health piece of our patients, right? And a lot of somatic complaints, a lot of things related to that chronic level of stress. There's that care gap for people who've put off care. And now we're trying to renegotiate, getting off those, as I refer to them, the COVID-19 pounds that many of us have kind of slumbered into just eating whatever we want to eat because we feel like we deserve to have something enjoyable these days. So, and then on top of that, just the aging population and people get sick every day. So yeah, it's a bit relentless, hey?
Yeah, and I'm finding a lot of my old patients are coming in, and they start off, "I haven't seen you in a year and a half, and how are you doing?" And after the chit chat comes out the piece of paper with, "Well, there's 9 things that have been happening that I want to talk to you about." So it's like I find the days more sort of cognitively burdensome, and patients haven't seen their doctor and they want to see them and they want to tell their story about what they've been through. And it makes for a different kind of day than pre-COVID and a different kind of day than during COVID.
Yeah, I had a patient the other day who legitimately came in to get her blood pressure checked for her birth control refill from a year ago. And we chatted about that for a few moments. And I said, "What else can I help you with?" And she's like, "No, that's it." And I just about fell out of my chair. And I took a moment to thank her actually, and told her that she was the easiest moment of my entire day. And, I've been accused of being too much of an optimist, but I grasp onto moments like that right now, Rick, that are those, those quick, easy wins. And sometimes it's just that, I remember to put my earrings in when I got dressed in the morning. It's like, wow, that was a win. And I think the fact that we always have a mental health moment to launch into these other conversations, I think is really, it wasn't necessarily what we planned to do, but it reminds us some of these techniques that we talk about and that we use with our patients would be a good idea to remind ourselves to, apply to ourselves when we can.
Yeah, we had a lot of really good mental health moments over the last year that probably, like some of our Netflix, are worth revisiting. So I also, before I invite you to share your slides, just want to highlight something that you said about our frontline staff. I think they are really getting exhausted and stressed. I know that we have up to 10% rates each day of our staff that are phoning in sick. They are just they went through the phase of telling people no, they can't come into the office. You can't come into the office, and now, well, you can come in, but it's not going to be for a little while. Access is challenging, so shout out to our frontline staff that really make our lives work and can be really the unsung heroes in primary care. So blessings to all of those folks, and a little bit of grace as well. Christine, you're going to give us an update on some point of care testing and also describe some of the work that we did around vaccine exemption letters. Why don't I turn it over to you to share your slides and chat along those lines?
You bet. Thanks, Rick. And so I've got my disclosure slide here for everyone to see, and you'll see that I've added a point at the bottom, which is to say that my job in the Calgary zone is an operational job, and I am not paid to be an advocate, although I try to advocate on behalf of family practice within my operational work. There are lots of family physicians, primary care providers, public health folks, et cetera, who are out there advocating for the best that we can do given the pandemic, whether that's on testing or, how things are going to roll out in our offices, et cetera. So please do not take any of my comments tonight as being me giving up, but rather, I suppose, drawing on my days as a brownie, which is always be prepared, twit, twit, twoo, and saying that, knowing where we could be, we're aiming there to provide some tools for you to use in that space. And we're actively working on that while others advocate and have those conversations provincially. So next slide, please. So I'll just pause here and maybe, this is a bit of a duplication of what we've just been chatting about, Rick, but I was doing an emotional check-in with myself as I prepared these slides yesterday. And I was thinking about, within a day, I can go from being completely and utterly freaked out and understanding what my patients mean when they say panic, to feeling completely demoralized when I've had another hard conversation with an anti-vax patient, angry at folks who don't want to get vaccinated, angry at myself for losing my cool when I'm talking to someone who doesn't want to get vaccinated, a sense of emptiness. After the COVID Corner presentation last week, I felt a little embarrassed because it's been hard in community family practice in a lot of different levels, but I don't even pretend to know what it feels like to work in ICU right now. Can't even fathom that. So thank you to our colleagues who are on the front lines doing that really hard work. But I'm also really digging deep to find a level of understanding. And in particular, I want to put a shout out to our family practice leadership and to one of our speakers tonight, Dr. Dina Hinshaw, who has, in my opinion, an impossible job to try to please everyone, and unfortunately feel, I'm sure, like she's pleased no one at the same time. And we're all going to be in different places, a different level of comfort as we move forward towards endemic state with COVID. And we have to be understanding of each other and understanding of people who are not ready to go fast, but also of those who are ready to move forward. I also feel a sense of determination, and I'm resolute in our ability as primary care providers to do the best for our patients and remember our Hippocratic oath and whatever version you partake of when you graduated, or even if you didn't say it, maybe you thought of those tenets when you finished med school and your residency and you went out to not just have the job of being a physician, but the calling. And finally, I'm deeply honored to have been given this role at the Calgary Zone and to work alongside Dr. Rick Ward to do these webinars, and that you all take the time out of your day each month over these last 19 months to join us and hopefully get a few pearls of wisdom that make tomorrow just a little bit easier for you. Next slide. So we wanted to talk a little bit about testing, and hence the terminology here. These are testing times for sure. We have some information from Alberta Precision Laboratories that, as you all know, there is continued mass testing by self-referral by patients. Right now, there is about a 1 to 3 day turnaround for those test results. And much of that depends on your location in the province, partly because of travel times for those swabs to get to the lab to be processed. So I want you to keep that in mind as we talk about some case studies later that Dr. Ward's going to present. At no point, and certainly not at this point, is primary care going to be expected to pick up and take the place of Alberta Health Services mass testing centers. as we move forward towards our endemic state. And there are lots of really smart folks, lots of really passionate folks who are working at a provincial level to try to figure out what's the sweet spot going to be there. But we know that the testing is going to have to shift at some point to a focus around surveillance, and that'll be through the Tarrant Viral Watch. And I've added the email address here if you're interested in joining the Tarrant Surveillance Network. I understand they're still looking for folks to join them. Also through wastewater, as we talked about stool earlier in tonight's webinar. That's another place where we can get a little bit of a view into the future of COVID case counts. If you missed the COVID corner where they spoke about that, or maybe it was our webinar, it's worth looking at again, really fascinating science. Testing is also going to shift in focus for clinical need for patient care planning. And we've got some cases we're going to reference this in later. Also in high risk situations, so think acute care admissions, etc. We wanted to just unpack a little bit types of testing that are or will be available in the community. So we're all familiar with the PCR testing, which is the nasopharyngeal or throat swab that is sent to the lab for analysis. And that can be done either at a testing center or in a community office by a physician. In some of our rural areas, of course, patients are maybe leaning in a little bit more heavily onto the emergency department for those swabs because of a lack of AHS bandwidth for that right now. We also talk about point of care testing, or POCT, what is often referred to as rapid testing out in the community. And this is the idea here is it gives you a quick answer, within 15 minutes, positive or negative, but there's real limitations to this testing around how it ought to be used, where's the sweet spot for that. So I've mentioned here that you should stand by for more information for the use of this in community primary care as we move forward into endemic state. We don't have specifics quite yet. And again, there's some guidance documents being worked on imminently at the provincial level that we'll be sure to make available with added layers of information and practical implementation within your office, as we've been doing over the pandemic. Serology really is for very select clinical situations only. There's been some concern about, fraudulent testing, et cetera. So patients maybe who are saying, hey, I had COVID last year, I want to do a serology test to prove that I'm still immune so I don't have to have a vaccination. There's just really no role for that. So serology is really meant for situations where we're doing studies. I know I'm in a healthcare provider study where I've had my serology checked on a couple of occasions, but that's information that is for research purposes only. And then finally, private testing, which really is for travel requirements and doesn't serve a role in the clinical management of patients or in the management of the pandemic from a population basis. Next slide. So I've got a hyperlink here to the recent scientific review through AHS with SAG. And this is a quote from that document, which is almost all Albertans can receive the COVID-19 vaccine and should. So we want to dig into some advice that we gave last week around vaccine exemptions and how to maneuver that in your office, because the advice on the Alberta Health Services website is to talk to your healthcare provider. That's us. And so we need to have a good explanation. And I think really a process and procedure around how to manage that in our office. Having those kind of rails on how we manage it allows us to kind of protect ourselves and I think our staff as well. Next slide. When we gave out the advice last week, it was after a synthesis of conversations we had via email with CPSA, AMA, AHS, Primary Healthcare Integration Network. And there's some things that we gleaned from that. So first off, you cannot have a blanket, I don't write or discuss exemption letters policy. You can't just say, I won't talk about that. That would be in contravention of your standards of practice. That does not mean, however, that you can just go ahead and grant every request that comes through. You need to have a good conversation and understand the request, the basis of the request from the patient, spend some time talking about the science around why an exemption would be needed, and make sure that you document that really carefully. We heard from the CPSA that really, if there were a concern brought forward from a patient about how you conducted yourself, that you would be judged based on how reasonable peers would have reacted in the same situation. And so we're quite hopeful that in opening up this conversation, that this allows you to see that your peers are reacting similarly across the zone. AMA has also got their vaccine positive toolkit, which is a super helpful resource, and it's being updated regularly. So as new information becomes available, that's a good place to go to. And there's lots of good scripts as well as tools that you can look at before you have a conversation with a patient to help you be prepared for those difficult conversations. And finally, if you missed it last week, the COVID Corner had a wonderful ethics and legal analysis around vaccine exemptions and vaccine passports, or whatever you want to call them. So if you missed it, it is definitely worth a watch. I found it quite interesting. And again, when we're in this stage where we're feeling very stressed out, having something that really piques your interest and gets your sense of learning going can be very valuable. Next slide. So again, the SAG review, which was published on September 7th, they said that there was almost no medical reason that would mean someone is not able to get one of the COVID-19 vaccines. And so the listed reasons were a documented severe allergic, that's anaphylactic reaction to a first dose of vaccine, or to a known vaccine ingredient, which is rare. If you develop a rare reaction, such as myocarditis, to the first dose of vaccine, and this is not a patient who said, I'm pretty sure I had myocarditis because my chest kind of hurt for a few days after I got vaccinated. This would be someone who had a physician-confirmed case of myocarditis, which would require actual workup to look at that. You should then, in that case, wait to receive the second dose until advised to do so by their specialist. And so that may be a conversation with a cardiologist, for example. That may be a conversation through public health in order to decide on the risk-benefit analysis of getting that second dose. And then they went further to say some individuals should only receive an mRNA vaccine, although that's probably a bit of a moot point right now in Alberta because we don't have AstraZeneca and we don't have Johnson & Johnson, although other vaccines may come at some later point. Right now, it is just an mRNA world. And so I've left the link there again to the SAG document for you to be able to take a look at that in its detail if you'd like. Next slide. So the peer advice that we put out last week, on September 2nd, we laid out 4 different reasons that someone, 4 themes for a vaccine exemption request. The medical we've talked about with regards to the SAG review, psychological, which would be, my 16-year-old who's needle phobic. So we did a lot of talking ahead of time. I actually brought home a syringe for her to hold on to so she could feel a sense of control over that. There's some neat devices that you can press onto the arm that have little nubbins into them that put pressure around the site where the needle will go in so they don't feel the needle go in quite as much. And as we all know, one of the main tenets for treatment of anxiety in general is exposure therapy, so gentle exposure to the things. So you may consider doing a time-limited vaccine exemption for someone to give them a week perhaps to prepare or to work with their psychologist around some exercises to help them be ready. And for patients who are really, really struggling, there is a low sensory clinic that was available through AHS, and so they can call 811 to see around access to that. For philosophical or religious reasons, now I point out here that absolutely all mainstream religious groups have put forward a comment that the community good for getting a vaccine is actually far outweighs any possible negative side of the vaccines from a religious perspective. You'll recall there was some original back and forth from the Catholic Church in particular, but all groups are now saying get vaccinated is in the public good. So this turns out to not be a clinical conversation and is really more around a personal conviction. And the whole point of a personal conviction is it's not really conviction unless there's a downside to it, frankly. So if someone has strong convictions to not get a vaccination, that does not require you to write them an exemption. That rather requires them to understand that their convictions will have a downside, and they must be willing, ready, and able to accept that downside. Now, that's not an easy conversation to have with a patient. And so in our advice, we also recommended that there may be situations where you want to truncate a conversation and follow up via phone. Now, I don't think that's cowardly. I think that's pragmatic, because you don't need to put yourself into a situation where you are potentially in harm's way, or where other patients and your staff are perhaps exposed to a conversation that goes the wrong way. And finally, misinformation, which is probably the bane of much of our existence with these conversations, as we try to coax and cajole our patients into vaccinations. Really, your only bet here is to provide evidence-based information and encouragement regarding immunization. But because someone has read on Facebook that the vaccine is going to make them infertile, you can refute that with the evidence that is out there and remind them that that is not their reading of information on the internet does not supersede the facts, which is that the vaccines are safe and effective. And so therefore that is not a reason for writing an exemption. We've got a hyperlink here to the vaccine exemption document that I referenced that we put out on September 2nd. We hope you'll find that that's useful. Next slide. And just a few quick reminders, third doses for our vulnerable populations, and that is a very limited list of patients. I had a patient today who called and wondered if her COPD got her in the list for a third dose, which it does not. My patient I saw today who has chronic kidney disease but is not on dialysis, likewise does not get a third dose at this point. And then for travelers, we thank everyone who did mixed doses so we could move forward with vaccines as fast as possible. And now we're paying them back by giving them a second dose of an mRNA so that they can have a nice clean profile for future travel purposes. Proof of immunization can be, patients can get that for themselves off of My Health Records and the My Health Records app if they want to have it on their phone. Reminder to you that you printing that off on their behalf from Netcare is an uninsured service. So you are able to charge for that. And, you know, whatever you might think about for maybe a reprint of a prescription or maybe a sick note, something along those lines. If you yourself provided the patient with the immunization and you did not give them a copy of paperwork at that time, you probably ought to give it to them without charging them. But if they've lost it or misplaced it, then by all means, reissuing that should be an uninsured service. And then a quick reminder about PPE. So we're all continuously masking still in healthcare appropriately. And right now you want to make a really, really good point of care risk assessment around adding back in, for example, your eye protection for certain patients. For example, one of my non-vaccinated patients today, I added my face shield back in for our 20-minute consultation. So I knew that I had that extra layer of protection. But we're going to get into some cases here that will allow us to maybe talk a little bit more about PPE. And I'll just check. I think that was my last slide, Trevor, but maybe just go one ahead. And it is. So Rick, I'll hand it back over to you for the cases, unless there were any questions that came up that you want me to handle now.
Yeah, no, I think nothing that came up specifically. I noticed Elaine on the chat mentioned that she had sent a patient to the low stimulus clinic and had a really positive outcome. So through 811 for those people who are really needle phobic. Nicola, yeah, so Nicola just asked in the chat, as anyone who's had sort of the mixed doses, are they eligible? And my understanding is that yes, that's the case. And Rajinder will definitely send that link for the document. Again, came out of Bow Valley and Yvette's leadership to say, hey, you know, can we have something for our members? So so good stuff.
And Rick, I just maybe want to chime in for the mixed doses. It's not just AstraZeneca mRNA mixed doses. If you got a Pfizer and a Moderna or vice versa, you get another mRNA. So you got 2 matching Modernas or 2 matching Pfizers. So I've had some patients inquire about that as well.
Great, thanks for clarifying. Because there's still lots of gray in our world in primary care, as always, we thought we'd come up with a few cases. Maybe, Trev, if you can just show up our first case. And this is really what would you do? And I've asked 40 of my closest friends, so I have a bit of a poll. So in this situation, we've got a 55-year-old woman who works in a grocery store. See the picture there? Thanks, Keith. She's been double vaccinated. She's going to go visit her elderly parents, but she's come down with mild cough, discharge, and sore throat. So in the next slide, here are your options. Do you do a virtual visit? Do you bring her into the office with full PPE? Do you say, go get a swab? Or do you send her to emerge? And the audience said, next slide, just about everybody says, let's tell her to go get a COVID swab. Christine, she's been double vaxxed. Is that really overkill?
Yeah, that's a great question. It isn't in the 4th wave because we know she's double vaccinated. She's got great protection, but she does work in a frontline situation at a grocery store. And, we all know that there are folks that are not always masking up in the grocery stores. And so, she is probably a little higher risk than other people who work from home and have very little exposure to the public. That being said, I guess the other thing we can think about, I think a great win on this one is no one said send to the emergency room or urgent care, which I love because our urgent care and emergency departments cannot be the overflow because we're feeling nervous in our community clinics. So I was really pleased to see that there was 0 on that one. And I guess we could talk a little bit about what happens if we can't swab.
Yeah, sorry, I was just distracted by the chat there. Christine caught me on away. So I know I won't answer your question by this statement, but are you seeing patients who've been double vaccinated who are COVID positive?
So I've been pretty lucky in my neck of the woods. I'm down in the deep south. And if you look at the local geographic areas on our Alberta map around vaccination, actually my little corner of the world is one of the sweet spots for vaccination, thankfully. And using my HQCA report, I'm able to see that 86% of my panel is vaccinated, double vaccinated. So in some ways, I probably have a nice little safe corner. But I have had 1 or 2 folks test positive who both have a lot of contact with the public, and we did manage their symptoms virtually exclusively. So I think in this situation, this is someone who maybe a little bit older, maybe is going to need you to look at them depending on how that virtual visit goes. But looking at the case counts, and I think Dean is going to mention this a little later, the majority of our cases are unvaccinated or partially vaccinated, but that doesn't mean 0.
Yeah, I can certainly speak to my experience in the office, and I've probably had a dozen new COVID positives in the last week. And in talking to them, I would say 2/3 have been double vaccinated. So I think this case that certainly reflects the reality of what I'm seeing. I'll point out that all the people who've been double vaxxed and yet have been COVID positive, their symptoms are pretty mild. I'm not seeing really sick people. So let's go to the next.
And Rick,
go ahead, Christine.
Rick, I was going to say, we talked about being in the gray, and I've certainly got some gray hair. You maybe have less hair, but would you say that these folks that are showing up double vaccinated but still getting sick with COVID, are they over 50 or under 50?
They are primarily. I am seeing a younger cohort. I'm seeing a younger cohort. I'm seeing more kids now. I had a 4-year-old that was a positive swab on the weekend, so it seems to be the younger folks. The one high risk 70+ year old, when we called him about his positive swab, he was laughing and saying, well, I was out cutting the grass just a few minutes ago, so that's how sick I am. So the vaccines work, at least from my perspective. Trev, let's jump on to the next case. We won't be able to get through all of them, but let's talk about this pediatric case. 4-year-old started preschool, other kids sick on day 3, even improving, and I think keyword improving respiratory tract symptoms. Initially, fever, nasal discharge, cough, appetite and activity level are better. And afebrile, preschool says, hey, we need a note from the doctor before she can come back to school. So next slide, what would you do if this was a call that came into your office? Would you do a virtual visit, make the assessment, send her back? Would you bring her into the office and have a good look at her? Or would you send this kitty for COVID swabs, or rare case, would you think you'd send to emerge? And maybe we'll just jump to the answers on this, Keith. So just about everybody is saying, you know what, she really needs to be COVID swabbed. Would you agree with that, Christine?
Yeah, and you know, I always have a little bit of a shake my head where the daycare wants a note for them to come back. I'm not entirely sure what the daycare is asking me to say in my note, other than to say, you know, if they want me to say this kid doesn't have COVID, then obviously they're going to need a swab. If they want me to say this kid is not going to transfer their virus to other kids, I can't say that. And frankly, you know, we all know what daycares look like. It's a place where a lot of viruses spread around, and that's the complexity we're going to be launching into in the fall here with the endemic state for COVID as well. So yeah, I think getting them swabbed and doing a virtual visit in the interim, because it may take a few days to get a swab and the results. And then remembering to counsel the parents that if they take a turn for the worse, to not wait for the swab to reconnect with you, because these kids under 5 can turn bad quick, and you might need to bring them into the office with full PPE to do a good assessment. But again, applaud everyone that they said 0% ER urgent care, because that's not where this kid belongs.
Yeah, I suspect that is Wayne Chang that makes a comment on the comment section saying, why not just bring her into the office and do the swab there yourself? What's your thoughts on that, Christine?
Yeah, you know, one of the most common emails I've had as a medical director through the entire COVID pandemic is, I can't get swabs. So I think there's some large clinics, and Wayne, you're probably one of those clinics that has a pretty good supply chain set up for the volume of swabs you've used. But some of us maybe don't have enough swabs to be able to do that on a regular basis. So I think it depends on your practice profile and your level of comfort with doing that.
Yeah, I agree. I think the only downside of bringing them into the office is this whole concern about exposing others. We've talked in past, and I know your clinic has a good protocol, Christine, where you bring people that are questionable COVID into an office at the end of the day or the end of the morning to reduce exposure. We've got about 6 minutes left. Let's try and get through a couple more of these cases. Trev, if you can put on the next slide. Hey, there's a happy looking 15-year-old, thrilled that he doesn't have to be doing Zoom grade 9. But 3-day history of progressive sore throat, fatigues. Mom saying he's tired all the time, a little bit of a dry cough. He's got these sore, tender glands. He's got a low-grade fever. Mom calls and says he needs to be checked out. I think there's something going on with this kid. So what are you going to do? Virtual visit? Get him and do one of those sort of opening up the mouth virtual visits, or are you going to bring him into the office, do the full PPE thing? Nope, just send him for a COVID swab, or are you going to send him to emerge? And here's what the 40 wise people said. Most of them are going to say, you know what? I'm going to send him for a COVID swab. Christine, doesn't this guy just have mono? I mean, are we going to send everybody for a COVID swab?
Well, and that's the kind of the catch-22 right now, because it is fairly still easy to get COVID swabs by patient referral, is that we're still all using that as our go-to. again, talking about moving forward and getting comfortable with changes in protocol as they will, because at some point, even, once the Delta wave is gone here, this fourth wave is gone here, things are going to settle down again, and we're still going to have sick people. And I'd almost argue this guy is so sick that he probably does have mono and doesn't have COVID, because most 15-year-olds with COVID are kind of like, not a lot going on. So myself, I would have probably brought this guy into my hot hour at the clinic and PPE'd up and swabbed him and gave him a rec to go get a mono test done, unless his exam was like screaming mono.
Yeah, no, I totally agree. And there's some great chats going on. Ling Yu and Ben, I like the comment about the advantage of sending these kids to the assessment center to get them swabbed is that they won't make us the bad guys, so that we'll still be able to bond with them. And holy smokes, Ja Yu, logging in. Good to see you, Ja, and a shout out to you, buddy. Let's go to the next case, and yeah, I think we'll have time for a couple. So another pediatric one, and you can see that Keith has picked out a great graphic. This kid does look pretty sick. 3-year-old has come down with fever, cough, 3 days after a family gathering where a non-immunized older cousin was coming down with RTI symptoms. I think a comment was made in the chat that a lot of these COVID positives are coming from non-immunized people. Child has only been symptomatic for 36 hours. Mom says, geez, I'm just concerned this child may have COVID from the evil cousin, and I think this child needs to be seen. Okay, so what are you guys going to do? Here's what the options. Again, virtual visit, bring her into the office for PPE assessment or assessment with PPE. Are you going to just say, no, go and be tortured by the assessment center? Or is this a kid that you want to send in? And here's what they said. Again, more people are saying, I think I want to see this kid. We've got some people who say, what are your thoughts on this case, Christine?
Yeah, I probably sit more of the both and, which is I'd love to get a COVID swab on this kid. But really, I'm a little bit more concerned about, could this kid have an ear infection or some other source for that fever? Again, given that little kids tend to be generally not as sick with COVID. Obviously not always, but generally. And so I would probably bring this kid in with full PPE because of how sick they are, and because I don't want to wait for 4 days to get a COVID result in order to decide that, oh gosh, now he's sick enough, he needs to be, admitted to hospital. So yeah, how about yourself, Rick? What would you do in your clinic?
Yeah, I'm going to go with the virtual visit, and I'll sort of wiggle out of this. I probably want to know a little bit more, right? I mean, obviously I've written, or the case is written in a way that it's ambiguous. So I would probably want to know. The virtual visit is really to decide between 2, 3, and frankly 4. My understanding, Christine, is that these young kids with COVID sometimes can go south really quickly. Wayne made the comment in the chat room that, could this kid have a big pharyngeal abscess, retropharyngeal abscess?
Yeah, and Rick, you make a good point there, because while I'm saying I would bring them in to take a look at them, I would probably talk to mom first over the phone to get as much history as I can. Because one of the other things, if you talk about point of care risk assessment and what PPE, how much PPE, et cetera, some of it has to do with the amount of time you're spending with the kid. So rather than having the 5-minute conversation and then examining the kid, if you've done a virtual visit first, you can bring that kid in and do a fast exam, and reduce your own exposure from a risk perspective. So that's something else, a bit of a hybrid almost.
Yeah, Kathleen makes the point as well about sometimes you're starting off with a quick virtual and following up. Listen, let's finish off with this last case, and then we'll bring Dina in. So 72-year-old dude living in the community, double vaccinated, but he's got risk factors. He's got the bad COPD, and he's got a little bit of diabetes, just a touch though. He's got a 2-day history of progressive cough, fever of 38.2, change in his sputum culture, lots of red flags there. Let's go to, again, our options. Let's see what the wise men and women do. Lots of distribution here. pushing towards bringing him in. Christine, what are you going to do?
Yeah, and I'm listening to this, and I think this is one of those benefits of knowing your patients real well, right? So, is this my 72-year-old Shriner who is double vaccinated but has been to like a whole bunch of large events because they've been, dying to get to those big events again, who has just traveled back from Montreal, or is this my 72-year-old who has hunkered down for the last 19 months, and he and his wife have done puzzle after puzzle, and he doesn't even go out to the grocery store because he's more sick than his wife from a chronic disease perspective. So, that knowledge helps me stratify this guy as well. So I'm thinking acute exacerbation of his chronic bronchitis. But, again, there's always that, is it good to know or nice to know that he's also maybe got COVID, so that because he's high risk of decompensation, and that's going to help me plan his care. So in a situation where I can't maybe get the COVID swab right away, I'm going to treat him for acute exacerbation and then make sure I get the swab too, so that I have that for in case he decompensates.
Yeah, I like that. Jane makes the comment about be nice to know his O2 sat, and I think we saw comments on that as well. Yeah, I mean, 2 years ago, we would have pulled out the COPD pathway and put him on amoxil and not followed him up as quickly. So I think your point about more than just throwing an antibiotic at him and ignoring that he could have COVID. So good comments, guys. Thanks. And Ben, on the chat line, your comment about can you bill for a virtual visit and a face-to-face on the same day, with my AMA hat on, and there's more and more skin here that needs to be covered through my discussions of this. We're still working on that virtual visit billing code. So.
But don't forget, Rick, if you spent 10 minutes on the phone and then they come in for an in-person, add that 10 minutes to your complex modifier timing, right? So it's not all is lost by doing that double in the same day, because it's any care is included in that complex modifier.
Right on. Thanks very much, Christine. Great comments in the dialogue box. And to bring it all home for us, Dina Hinshaw, who has been the busiest person in the province and has ridden the waves much more so than anyone else I know. Dina, it's really good for you to join us. You probably missed Christine's comments earlier and the accolades that came through in the chat for you, but looking forward to hearing your wisdom as of September 13th. We know it's going to change, but looking forward to your comments.
Thanks so much. And as I said to you before the session started, I just want to thank you for still talking to me. I know that there's a lot of frustration, a lot of anger, a lot of exhaustion out there. And I just wanted to start before I get into my presentation, because I know one of the questions that certainly clinical colleagues I hear from is like, what were you thinking? Why did you say we can go to endemic in July? So I just wanted to, I guess, start with a little bit of an analogy, and then I'll talk through some of the data and forward planning. But as many people may or may not know, I trained in family medicine with a 6-month care of the elderly specialty, and then practiced for a while as a care of the elderly clinician in a referral clinic before moving into entirely public health. And as I was thinking about the last couple of months and all of the different things that have happened, to me, I think about when I was working in care of the elderly with geriatric patients, and you have a patient in front of you who has a lot of complex health issues. And to treat any one of those health issues, sometimes the treatment exacerbates another one of those health issues. And you're trying to find that right balance between the overall health of that patient in front of you and knowing that there's trade-offs to all of those things. The other thing that happens in care of the elderly, which I'm sure happens in other areas, pediatrics probably as well, is that you don't just have that one patient. You often have their family members, you have other caregivers involved, and everyone has opinions and everyone has different beliefs and values. And you're trying to find the way through, especially if that patient has cognitive impairment, and you're trying to work with proxy decision makers who are making a decision on behalf of that patient, and you're trying to figure out how do you balance the attitudes, the beliefs, the values, and all of these different pieces of that person's individual care plan to try to come up with the best way forward. And so, if you think about that analogy in terms of my treatment of the population as a patient and where we were in July, and after having lots of discussions with colleagues, and really most of my colleagues, particularly in Western Canada, were really feeling like the evidence was such at that time that with the levels of vaccine we had, certainly the Public Health Agency of Canada had indicated at least 75% single dose, about 20% second dose. Opening was reasonable, with increasing second dose coverage, anticipating that we would have a similar Delta experience to the UK, that it seemed like that was an appropriate time to start that transition to say, we will have cases, we expect there to be a decoupling of acute care, and to start walking down that path. It was a very abrupt transition. I know it landed very, very heavily for many people. It felt like a 180-degree switch, which doesn't help people understand that endemic doesn't mean we've dusted off our hands and we're ignoring this. It means we have to figure out what's that sustainable way to manage it. But of course, the expectations did not match reality, and very shortly after we started that endemic path, we could see already from that comparison with actuals and the modeling data within a couple of weeks that we weren't seeing the decoupling we expected, and really had to shift and walk back about, okay, we're not ready yet. We need to take more time. And as everyone knows, we've needed to put additional measures in place. Clearly, we're in a significant challenge right now with respect to our acute care system. And the comments earlier about the burdens that clinicians are carrying in acute care and primary care is significant. And I feel very responsible for the narrative that has made it more complicated to try to put additional public health measures in place, because whether or not it was my intention, what was heard at the end of July was COVID's over, we can walk away and ignore it. And that has had repercussions. And I deeply regret how that has played out. I do continue to do my best every day to provide my advice to the proxy decision makers for my patient, who are the elected officials. And I think that if you think about, if you're caring for a patient who you're working with, again, that kind of broad scope of many people who have different interests and beliefs, so you're trying to balance the treatment plans. Again, that's sort of a microcosm of what I have been trying to do, and really appreciate again the opportunity to chat tonight about some of the where are we now, how did we get here, and then where are we going forward. So I'll just I'll share my screen. I know there's going to be time for questions afterwards, but
and Tina, as you're sharing that screen, I just want to say that for those of us who've walked along the journey with you, which I think is just about everybody, I think we all know that the decisions and the suggestions and the advice that you're making in your heart is coming from the right place. And the line that I've taken up with patients and family is that, in the next pandemic, we will do this so much better with what we've learned. So bring it on. We're ready for it. Sorry.
Oh my goodness. I hope that's not going to be necessary. Can I just check and see if you're seeing the slideshow or, oh yeah. Okay.
Yeah, we're right on.
So I'll just go through these slides, and then hopefully we'll have some time for discussion, because that's always the most interesting part anyways. So my disclosures are brief. I am, of course, a contract employee of the government, member of the APL Advisory Board, and have affiliations with both the U of A and U of C departments of medicine. So I want to talk a bit about context, where we are now, what we are looking to likely experience in the fall, endemic state, when do we get there? I'm not quite sure. And then primary care implications, which have already been very well covered. And I wasn't meaning to lurk. I just turned my camera off because I was trying to do some other things, but I actually did listen to the other presentations. So, so I think that some of those primary care implications have already been well covered. So just in terms of context, I think it's really important, we're all so focused on Alberta, and obviously Alberta is in a significant crisis state right now. There's no dancing around that, but I think it's really important to remember that Delta kind of caught a bunch of us unawares. So certainly again in Western Canada, we looked at all the data that was available at the time in July and felt that it was an appropriate time to really open up activities, knowing that the interventions that we've needed to use to control COVID have been harmful in many ways. And I'm sure you've seen that in your own practice. But unfortunately, Delta has spread much more quickly and has had more severe outcomes than we anticipated. And that's something that's been seen in many places around the world, certainly in all of the Western provinces. This has been our experience over the summer, and of course, varying degrees of restrictions at different times that have come in have had different impacts in the 3 Western provinces. But you can see again, this is something that's not unique to Alberta. We're all really struggling with this, including in some of the states that have similar vaccination rates to ours. So I just have Washington and Oregon there as a comparator. Globally, again, this is a bit of a messy map, but you can see that we're Alberta's a bit middle of the pack in terms of where we're sitting with our current per capita COVID 7-day average new cases. And again, about middle of the pack in terms of where we're sitting with our 7-day average in terms of acute care burden. But it doesn't necessarily mean, and of course, there's certainly many, many countries that aren't on here that have done a really excellent job at keeping COVID very low for a very long time. And so these are comparators in terms of countries that have used a similar attempt to not drive to COVID zero, but rather to try to, again, balance restrictions with the kind of COVID impacts. So where are we now? We know that right now we're not catching as many cases as we were before. So our serology results that we've been tracking over the course of the pandemic, and that's the residual serosurvey that the lab has done the first week of every month. And so we have that data in a publication that's available there's a link to that publication in the evidence summary that we put out a couple of weeks ago that indicated when you take waning immunity into account that we have been catching about 1 in 4 of our COVID cases through our PCR program to date. And that's not an indication of the sensitivity of PCR. It's mostly an indication of how many patients don't go for testing at all, even when they feel sick. What we have seen happening, so of course we did change our testing protocol somewhat at the end of July, where we are no longer offering universal testing to close contacts without symptoms. So we are really focusing instead on people who are symptomatic, and we are doing outbreak testing in places that are high risk, even when people don't have symptoms. But the combination, potentially partly because we are not doing those close contact tests, but also I think again, the impact of the messaging that was received about we don't need to worry about COVID anymore, whether or not that was the intent, I think has also impacted people's willingness to go for testing. So you can see that even though we have lower case numbers than we've had in previous waves, of course, our acute care burden is significant. And this is just data as of Friday. And as you likely know, we have now exceeded, and we're at that 200 mark for patients in ICU with COVID, which we've never reached before. Our maximum was 180 patients in ICU in our 3rd wave. And so we have a crisis. That's clear. I think everyone is well aware of that. And so unfortunately, that's again, what we had started to see in early August. We had paused, we'd evaluated, and then by kind of mid to late August realized this is a significant problem. We need to pull back, and we're still in that process. There's a lot of conversations around breakthrough cases. And so what I wanted to show in these graphs, and this is data that comes, I don't think I put the ULI on the slide. Normally I reference my slides, but this is from our public facing dashboard that provides vaccine outcomes. And so every day there's an update as to the new cases, active cases, and hospitalized cases by their vaccination status, complete, partial, or unvaccinated. So you can find this data on the website. But you can see on the top left that 60% of our total population, including children, so this isn't eligible, this is total, are fully vaccinated, with another 7% with 1 dose. And then, of course, about a third of our total population is completely unvaccinated. And so you can see, as you compare that gray area in the chart to the hospitalized and active, that although the unvaccinated individuals in the population are the minority, they are the majority of those who end up with COVID or who end up hospitalized. And again, this is the active case snapshot is just those who go for testing. And so there's always built-in bias in terms of who is interested in testing, who's going for testing. We certainly know that we've seen an uptick in terms of the number of people when they're called by the case investigators, as we are still doing universal case investigation, and there is still mandatory isolation, which not everybody, I think, understands, that people are more and more angry about being told they have COVID, being told they have to isolate, and there seems to be, again, as was said earlier, I think Rick, you mentioned people saying, "I'm so done with this COVID thing," and really taking it out on the case investigators because they don't want to isolate. They don't want to have to do anything that restricts their movement. And so if you think about that, if people have chosen to not be vaccinated, again, this is a conjecture. I don't have proof of this, but I do wonder if those individuals may be even less likely to seek testing, if they're less likely to really want to be diagnosed and have that impact on their lives of that mandatory quarantine. Of course, technically, there still is a mandatory isolation order for anyone with COVID symptoms. So technically, it doesn't matter if they're tested or not, but of course, it's just possible to police that. And then you can see again in the hospitalization that there certainly is a number of people who, even though they have 2 doses, still end up with severe outcomes. And we have seen, I'm sure many of you have seen in your practice, individuals who have 2 doses of vaccine and have still gotten COVID and have died. And that's very concerning. Certainly in the last, I'd say 3 to 4 weeks, we've seen a lot more individuals who have had that kind of severe outcome, and it's tragic. I get fastest means possible reports of every single COVID death. And I see those coming across my desk, and every single day wish that I could prevent every single one of those. I also see the reports of things like pediatric mental health and eating disorders and opioid deaths. And again, wish that I could prevent all those things. But ultimately, we are doing our best to try to manage this particular situation, as we are seeing some of that start to take hold. Part of that is as we see the transmission rates rise, it's kind of like a forest fire. If you consider vaccines as the fire suppressant, you're watering down all of the flammable material. The hotter the fire gets, the more it can kind of creep into that group that has the vaccines on board. Although, as has been mentioned here already, it does greatly reduce the chance of severe outcomes, even when there is breakthrough disease. But we also know that in those who are very old and frail and medically complex, unfortunately, having a COVID infection, even after being doubly vaccinated, may be that thing that is just the one medical problem too much. And we also know that 90% of our population, 75 and older, has 2 doses of vaccine on board. So when we look at the raw numbers, it's really important to remember that the numbers don't tell the whole story. You have to look at the denominator. So if we have 5 deaths in people who are fully vaccinated and 5 deaths in people who are unvaccinated, but the denominator of the 5 deaths is 10% of the population, and the denominator of the other is 90% of the population. Again, vaccines still greatly reduce the risk of severe outcomes. In terms of fall projections, again, these are the projections that we put out a little over a week ago. So not a week ago, last Friday, when we imposed when there was a decision made to put additional restrictions in place. You can see that we continue to increase over the curve trajectories. So we'd moved in the ICU from our low to medium, and now we're moving up towards the high again, recognizing that these are data as of Friday, and it's gone up even more since then. And you can see the non-ICU continues to track along that high line. So again, I think we're in a very significant situation when it comes to critical care capacity, and that's something that that needs serious attention, and is getting that serious attention and lots of discussion and debate. But I think what we will see this fall, I'm not sure when the fourth wave will end. I don't know exactly what will happen in the next week. I do know that when we've looked at other jurisdictions, so for example, looking at Oregon and Washington, their ICU numbers peaked at what would be the Alberta equivalent of about 350, and their case count started to come down, and their ICUs peaked and then started to come down the other side of that. The US states have a lot more residual acute care capacity than we do. They don't run at capacity. They were able to absorb that, and we can't assume that we would have that same experience here. But I think it's likely that we will, again, one way or another over the next several weeks, be coming to the other side of the fourth wave. But within any wave, you have to remember that coming down the other side, you have the second half of it, right? So we've had a huge amount of cases already. We're still going to see a lot of cases even as we come down the other side. So there is still, unfortunately, quite a while yet before we're going to be through this particular wave. Just a bit about endemic, and I've spoken a little bit about this before already, but endemic does not mean, and was never my intention to convey, although I recognize that I did, that endemic means to some people, well, then it's just back to 2019, 2018, we don't have to do anything different. To me, what endemic means is that this is a disease that we're no longer trying to control, one case at a time. And I think as I was listening to some of the earlier conversation about who gets testing and how patients are managed, I think that one of the pieces of feedback that I heard most strongly when we announced the intention to shift away from universal testing and do clinical testing is, I think, a feeling of, but how will I know how to manage that particular patient, whether or not I can bring them into the clinic? How do I know how to manage them if I don't know if they have COVID or not? And I think that, again, from my time as a family doctor, if I had even for influenza, the ability to have a patient go for a relatively quick test for influenza, that I didn't need to bring them into the office, they could just go get that done, and I had that information then to manage their care, of course I would take that. Of course it makes sense. If I was asked, do you want to manage this patient with more information or less information? I will always choose more information. The challenge is that we set up a testing system not to manage individual patient care. The testing system was set up because, especially pre-vaccine, one of the foundational ways we had to manage the pandemic was to identify as many cases as we possibly could and put controls in place around those cases and their contacts. And we're in this sort of awkward middle ground right now. We have stepped away from contact tracing. I know there's lots of debate about that and concerns that that's exacerbating our current state. I think when I've looked at the trajectories in our neighboring provinces, would I have taken away contact tracing if I'd known this was going to be the fourth wave experience? I don't think that would have been the right time to do it. But once that had been taken away, to try to build it back up again in a time where we need healthcare providers to provide individual clinical care, we need them to do the testing. There's a shortage of individuals to do all of these roles. So to bring healthcare professionals in to do the contact tracing, especially when I looked at our own trajectory of cases, when I looked at our neighboring provinces, really at this point in time, I think what the interventions that will make a difference are the other public health interventions. And so this is a bit of a tangent, but just to say that I don't believe that contact tracing change has had a huge impact on our trajectory. I think that trajectory was set when we removed all the public health restrictions at the beginning of July. And I think if we look at the experiences of all of the different provinces across the country, those that have kept in some base level restrictions to manage the interactions and close contacts are the ones that are not seeing the significant impact. And those of us that remove them are the ones that saw the significant, very steep rise in some of these acute care impacts. So all that to say, back to endemic, the reason we've been doing the massive amounts of testing is to try to control the spread through that public health kind of whack-a-mole approach, trying to get at all of those individual cases. But we can't sustain that forever. And so it's going to be a challenge. And that's, as Christine referenced earlier, one of the things that we're working with primary care on, to think through who is going to benefit the most from an individual clinical perspective in terms of having a test to know whether or not they have COVID, and how will that change management. And we know that there are some therapies that have been used mostly in the US on an early outpatient basis for people who have risk factors. So monoclonal antibody therapies to try to minimize the risk of severe outcomes. But these are intravenous therapies. They're very difficult to source in terms of having them in large quantities. They're extremely expensive. And so I think at this point in time, it's really important to think about, how would I manage this patient differently if I knew if they had COVID or not, for that future endemic state. To be clear, right now, I think we still do want to know about as many cases of COVID as possible. And so in the earlier scenarios, I think it's totally reasonable, if you think a clinical presentation looks like it could be COVID, totally reasonable to send them for that test, so that there's not just that individual clinical management. But at this particular moment in time in the fourth wave, I think it's as important as possible to try to get those cases diagnosed, and again, make sure that we are able to put in some of those additional public health. But going forward, once we hit this stage where we're no longer in a place where the healthcare system is in danger of being overwhelmed, we'll continue to see an ebb and flow of cases. And then thinking about, how will this test change this individual patient's management, is going to be the most important driver of choosing testing. It's going to be important to recognize that there's a lot of talk about boosters and whether or not people need to have a third dose outside of those groups that are currently eligible, which are residents of continuing care facilities and people with immune compromising conditions for clinical reasons. And I know there's a lot of discussion about, well, do older individuals in the community, so seniors over a particular age, do they need a third dose? Do younger people need a third dose? We know that unvaccinated individuals, even if they got a third dose, there still will be some people at risk of infection and severe outcomes. Vaccines are not perfect, and we will continue to see that. And the question about booster dose, we will need to watch for and consider. But at this particular moment in time, again, we're really focused on those at the absolute highest risk, which are the groups that I've mentioned. Right now, particularly in the fourth wave, but even as we go forward, and at times, if we do see increases in community transmission at some point in the future, older individuals, those with immune compromising conditions, will need to be careful, unfortunately. Some people will not fully respond to vaccine. And so counseling those individuals about the precautions that they need to take at an individual level to minimize their exposure risk will continue to be important. We will need significant measures in continuing care and acute care. And we did make a determination in the summer that those were settings that would retain some of those measures through to the end of the next respiratory virus season, because, again, no vaccine is perfect, and we know that these are particular settings of risk. So that's something that we will keep in place, again, for the remainder of this respiratory virus season. And we'll need to have a lot more conversations about, how do we manage this when it gets into that endemic state? What are the sustainable and livable measures? Because we know in continuing care that isolation and mental health considerations, especially for people who have a relatively short life expectancy, and they may be quite willing to take a risk of getting infected with COVID, even if they have a severe outcome, if it means they can spend more time with people that they love. And so those are the kinds of trade-offs that we really need to consider and make as we're looking at sustainability. We obviously need to watch for new variants. Certainly that's something that's highly likely to see. We've seen these dominant waves of variants come and go, and we need to be mindful of that. But over time, and I know, Christine, you mentioned this, what are the things that have become important through COVID that we can take with us and hopefully improve our habits going forward? I liked all of the ideas about the kind of positive reflections and some of those mental health pieces. This is more of the biological kind of infection control stuff. But again, thinking about what are those things that we can build into our daily habits going forward. So these are things that you can tell me better than I can tell you. But of course, in terms of primary care implications for endemic, first of all, I don't know when we're going to get to a true endemic state. I think it's going to be a bit of a waxing and waning over the next while. Certainly, as you know, we have deferred any change in further testing or isolation measures past September 27th. There's currently no set end date. And I think we need to be extremely cautious about that next date because obviously we can't, just when we think we understand COVID, it takes another turn. And that's something that we need to be really mindful of. One of the significant issues that's been raised to me in terms of that testing change for primary care are the barriers to infection control practices and the thought that people could go back to what a previous normal would have been. So primary care clinic, certainly when I was practicing, I don't think I ever donned PPE to do an influenza swab ever in a primary care clinic. So what does that look like going forward if we're taking away the assessment centers? There's cost implications, there's infrastructure implications, there's all sorts of things that primary care needs to deal with. And of course, each primary care is an independent business. So there's all sorts of considerations that we need to take into account. I've already talked a little bit about the testing protocols, and we are working with primary care leaders to figure out, again, probably the first iteration of guidance. We're not going to get it perfect the first time, but trying to get something that at least gives that overview, and then the iterative process and listening to primary care physicians and others to have feedback loops of what makes the most sense. And going back to my initial analogy of working in geriatrics and having a kind of that complex patient who has multiple issues, and you're trying to balance the treatment and all of the different clinical issues. I think the thing that I would close with is to say that some of in my mind, the times where I felt like the public health policy has best been patient-centered clinical public health is when we've had the opportunity to have significant feedback and input. So for me, some of the most valuable conversations have been when we've been trying to work through continuing care policy. And as you may know, we've had many town halls with continuing care stakeholders open to family and residents and staff and operators of continuing care to try to get feedback on what is that right balance between restrictions that protect people from COVID, but not imposing so many restrictions that people experience significant mental health impacts or other impacts. And we haven't done that for various reasons in other sectors. So again, policymaking is complex, and I am one part of a large machine. But I think that if there's any way that we can do that in primary care to be able to spend more time with the people at the front lines and understand some of these complexities. We don't always have that opportunity. We don't always have the time or the ability to share what would be considered confidential information in advance of a policy decision. So it's not always possible. But I do think that patient-centered medicine does involve considering those needs, values, wishes, wants of the patient, and your patients. And so being able to work with you and understand how people are responding to this will be really valuable. And my last slide is just a visual metaphor of endemic is sort of neither stop nor go, but a bit of a combination, which can be frustrating. And one of the concepts that I found helpful in my kind of thinking about not just the pandemic, but about public health in general is the concept of polarity. So sometimes we tend to see things in an either or kind of way. And the thinking shift that is often important is thinking about the both and. So, and that's, I think, again, the trouble that I got into by using that endemic terminology in July was that people heard it's either pandemic in case it's really bad, or it's endemic, which means, oh, it's not a problem at all. And I think it's a both and thing. COVID is very serious. If someone's not immunized, they have as high, if not higher risk of getting sick now than they ever have. So endemic doesn't mean ignore it, right? So COVID is very serious, and we still have to learn how to live with it. And so trying to figure out that right balance and that tension between those two polarities is going to be critical. It will take all of us, and it will take extremely difficult conversations because there's a lot of division out there, and there's a lot of polarization. And I can only just say thank you to all of you for continuing to show up every day in your roles, and for giving me the space tonight to talk a little bit about where we've come from, where we are, and where we might be going. I think the one thing about COVID is none of us know for sure exactly what will happen next, but I'll leave it there and turn it back, Rick, to you for any questions.
Yeah, thanks so much, Dina. And I guess a couple of the things that you said I wanted to highlight on. Your comment about dealing with the complex elderly, and how you're trying to walk that balance. And I think for all of us who've managed a volume overloaded congestive heart failure patient with compromised renal function, and you're pushing the Lasix and watching the creatinine go up, and the electrolytes go all wonky, and it's a dance. And I think about a few of those kinds of patients of mine that have ended up in Emerge, and realizing that clinically I haven't always done that dance very well. The second thing that you said at the very end, that two things can both be true. Earlier in the webcast, we've had Amanda Berg, a really great psychiatrist colleague, talking to us about DBT, dialectical behavioral therapy, and one of the tenets of that is that two things can be true and coexisting at the same time, but can seem to be be opposed to each other. It really seems like your last comment is, Amanda Berg could have said it, that, two things can be true that seem not to be able to coexist, but are true. So maybe again, riffing back to Val's talk earlier today, and some of the previous mental health wisdom, maybe we all need to take a little poop pill and then go back to our DBT stuff, and all of this will make perfect sense. But listen, I want to, there was lots of comments on the chat, and as Christina said, tonight is more about looking ahead than it is in the rear view mirror. To my colleagues who've expressed some heartfelt comments in the chat line, we'll make sure that Dina gets those, but I'm not going to ask her to respond to that, because there's lots of questions about the future that maybe I want to throw out that have come up in the chat, and one of those is about masks. And for the love of goodness, should we be masking our kids when we send them to school? Do masks really work? Where are we with that as of September 2021?
Yeah, it's a great question. Unfortunately, masks have become one of those lightning rod issues that people are very divided on, and kind of a symbol in a way, of course, for some people. There are people who believe that masks impair oxygen supply and can be actively harmful. I think the evidence around that is quite clear. I don't think there's any credible evidence that wearing a mask impairs oxygen supply in a significant way, that it's harmful for kids. I think that there's other implications of mask wearing, and communication is one of them. Certainly, there are, I think some people, again, experience mask wearing, whether it's because of previous traumatic experiences. Like, I think that it's also important to not completely write off the fact that some people do experience negative consequences from mask wearing. So even though, again, from a broad clinical perspective, physiologically, I don't think that's the case. There are other factors at play. Having said that, I also believe that there is a strong body of evidence at this point that regular mask use is an important additional factor in terms of COVID control, and that wearing masks in schools again is a huge lightning rod issue. I provide a series of recommendations, and then those recommendations are considered and decisions are made by others. I think that it is a very reasonable thing to have kids wearing masks right now. We know that, again, the transmission risk in the community has never been higher since the pandemic started. We have no evidence from our own experience or across Canada that as an individual risk to a child that a Delta infection is much different than previous infections. That doesn't seem to be the case, but even with a low risk, it's not zero. So if you infect huge numbers of kids, of course, you will see an increase in the total number of kids, those rare kids who do have those serious outcomes. So yeah, it's tricky because in schools in particular, we know that closing schools is the worst possible outcome. We need to keep schools open. We know that kids need that kind of in-person interaction for their development, for their health. My own two are under the age of 12, so can't be vaccinated. They're in school. And I think it's important to do the best we can to keep schools safe, but I also think we need to recognize that it's not going to be zero risk. It wasn't last year, it won't be this year. And it's again that kind of tension of trying to do the best we can, while at the same time really being realistic about the kinds of risks that we're okay with, and recognizing that a kid's risk of ending up in the emergency department for a sports-related injury is multiple times higher than the risk of admission for a COVID infection. And so I think, again, as we think about COVID for our kids, sometimes we're tempted to focus on this as the one key issue that we need to protect from at all costs. And I think that if we try to kind of take that step back and look at that big picture of all the things, and this is tricky. Sometimes I wonder if public health causes anxiety, because we like to tell people, oh, if you do that, this is going to happen. If you do this, this is going to happen. And so I think that's problematic, because I don't think that we need to be worried about everything that could happen. But I think what's important is again, trying to look at the big picture and recognize that we're just not cognizant, or we don't think all the time about some of those risks our kids face. And so we're comfortable with them. And it doesn't mean we should be okay with, willingly exposing our kids to COVID, but we just need to weigh out those risks in terms of what are we willing to accept and what are we not? And then making those decisions that are right for our family, for our kids. I don't know. Sorry, that was a really long answer, but this is a tricky question.
No, and we saved the easy questions for the last speaker. So sorry, all we have for you is the hard ones. Listen, I don't want to ask you a question where you have to plead the fifth or the fourth or whichever one. But what are your thoughts on vaccine passports? And I recognize that there's a lot of politics in that, but maybe putting it in a different way, is there evidence from other jurisdictions that vaccine passports may have a positive public health impact?
Having talked to colleagues who've implemented that approach in their jurisdictions, I think it's pretty clear that there is an impact. So I actually just received some information tonight from my colleagues in BC, and it was interesting because when they looked at the impact that their announcement had within the 2 weeks following their vaccine passport announcement, there was a differential increase in the uptake in the younger age groups. So if you look at the overall population change, it kind of masks some of that interesting. Sorry, I should turn my light on just a second. Anyway, I won't look like I'm glowing. So what they saw is in their 30 to 39-year-old age group, in the 2 weeks after the announcement, they had an almost 3% increase in that population uptake, as opposed to over 50, where it went up 1%. So if you look at the whole population, it kind of can mask what you see in 18 to 29-year-olds. It went up about 4%, a little over 4% in 2 weeks. So again, I think it's pretty clear that requirements, especially for discretionary activities, can have an impact in those age groups where we most need right now to increase our uptake, because that's where it's the lowest. So I would say that that's been the experience of other jurisdictions.
And good answer. And what about vaccines in kids? Do you think that, do you see that on the horizon?
What we understand is that Pfizer should have the data for 6 to 11-year-olds, or 5 to 11-year-olds. My understanding is they should have that by October. And so it usually takes a while. Health Canada needs to review the data. The National Advisory Committee looks at the evidence around particular populations and burden of disease. And there's actually a really interesting debate amongst different public health perspectives for those younger kids, because they are the absolute lowest risk of severe outcomes. And yet, of course, they are part of the population. They can contribute, if they're non-immune, to potentially passing the virus on to others. And so there's the question of, should we be providing them with immunization for their own protection? Should we be providing them with immunization for the benefit of others? There's also the benefit that the less likely that COVID spreads in the community, the less likely that the activities that kids need for their growth and development would be interrupted. So we've had some interesting conversations over the past several months looking at the ethical implications of different vaccines in different age groups, because I think it's really important for people to remember that just because we have a vaccine available for an age group doesn't necessarily automatically mean that we should offer it. And I'm sure people have been following the debate in the UK about immunizing 12 to 15-year-olds. And I think it was just in the last couple of days that I think the sort of equivalent of CMOHs there have come out with a statement that they do recommend it. And that's different from their official advisory committee, which was weighing out those myocarditis risks and the individual risk of severe outcomes. And so same thing for those younger kids. And we'll be really interested to see the data. I know that it's a lower dose that they're using in younger kids, which hopefully will mitigate some of that myocarditis issue. But we don't, in public health, just, okay, good, we have a vaccine, we should use it for everyone. Like, there's all of those steps that are really important that we need to take before we can determine what the best recommendations are.
Dina, the last question, I guess, is a family doc question. How are you and your colleagues doing? This has been a tremendously unprecedented 18 months. How are you and the other medical health officers doing?
I mean, I think it's hard for us as it is for all of you and for everyone else. I would say, I'm not sure if any of my colleagues are on the call tonight in terms of local public health. I think it's really hard in local public health because this has been such a provincially driven response, and typically public health is very local. Typically public health happens at the local level with local relationships and often local decision making about what's the right thing for that particular group of people. And especially for COVID policy, that's not really been possible for various reasons. So if you happen to see a local MOH, any of you in your travels, just tell them they're appreciated, because they're kind of stuck in the middle a lot of times. And so, I mean, it's been tough, right? And I would say the team I work with at the ministry in the Emergency Operations Center, there's a group of people who've been working essentially nonstop since late January of 2020. Like, and I'm talking weekends, evenings, holidays, like every single day. And it just is tough because people want to know what to expect. They want a guarantee that you can say, okay, well, in 1 month it's going to look like this, and in 2 months it's going to look like that. And that's never how COVID's worked. And people, I think, get frustrated and say, well, it's 19 months in, how come you can't tell us? Like, clearly you're not good at your job if you can't tell us what to expect. And it just keeps changing. And so it's very, very challenging to yeah, have gone through these cycles with the team, and I can't say enough good things about the team that I work with and their dedication and how hard they work and how much they care. And so it's just tough, especially right now, because it is just such a difficult time for everyone, and to try to do our best in this difficult time. It's hard. No question.
Dina, thank you on behalf of those that are listening today, and our broader colleague base, and the citizens of Alberta. And maybe a good take-home message is when you see your public health officer, provincial health officers, give them a COVID hug. I'm not sure what a COVID hug looks like, but it sounds like good medicine to me. Dina, thanks again. And we'll just wrap up with our final slide, which will not be how to do a COVID hug. I think that's our next webcast. Listen, thanks for attending. I know there was some passionate dialogue in the chat. What I will commit to is seeing about getting some comments high level on some of the concerns that were raised. It just wasn't the forum tonight to be able to dive into some of those things in the rearview mirror, but I fully appreciate how people are feeling that there's questions that they have from the past, and we're all experiencing things right now. So please take that survey. Remember that we get the 1 hour study credit, no, 2 hour study credits for this. We're going to be back next month unless COVID goes away. And I am going to offer the last word, as usual, to my partner in crime, Christine. Christine, do you want to take us home?
Thanks, Rick. And I think one of the things that was a common theme in the chat, and you'll forgive us for not bringing it forward for comment from Dina. Lots of questions about, what to expect, what's happened in the past, why has it happened, etc. And thanks to Dr. Scott Beach, who commented on some different groups that you can connect with if you want to make sure your voice is being heard. And then also for those of you who are members of PCN, of course, there's the board chairs of your PCNs who have an opportunity to talk to our local primary care leader, Dr. Ernst Grabenstein, who sits at those provincial committees, and I know has spent a lot of time with Dr. Hinshaw working on that primary care guidance, et cetera. So we didn't bring those questions forward this morning or today, not because we don't value your thoughts, et cetera, but more it wasn't the venue that we were trying to create here. So thank you for taking those other opportunities to have your voice be heard. Thanks a lot, Rick.
Night, everybody. See you next month.